So, good morning or good day, everyone. This time we will be talking about pharmacologic management of depression. Earlier on in a previous um, video recording, I was talking about pharmacologic management of anxiety. So, this time we will enter into the world of mood disorder. Under mood disorder, there is depression, which we identify as unipolar mood disorder, which is basically one-sided, which being depressed. Because I don't want you to be confused, because following this would be your bipolar disorder. It has two spectrum, an up mood, which is mania, and a down mood, which is depression. But in this presentation, I will focus first on the unipolar disorder called depression. As what we have established when I was talking about anxiety disorders, I started with the physiology, the biological basis of the disorder. In such a way, I started with a biological basis for anxiety. I would do the same in discussing your depression. I will start with biological basis of depression, upon which we could manage through the use of pharmacologic method. So, although depression is identified as multifactorial, just like many of your psychiatric disorder, I will discuss depression in a realm of biological basis, because that is where upon which we will be able to manage and incorporate pharmacologic means to manage depression. Again, as I've said, although it has multifactorial, it has psychologic basis, heredity, genetics, but in this case, for purposes of discussion using pharmacologic management, I will be zoning in and focusing on the biological basis. That's where upon which we could manipulate, the neurotransmitter in order to manage pharmacologically the disorder. So that is where our premise will be. I will start with discussing the biologic basis and then roll into the various classifications of pharmacologic agent that we could use to manage depression. So remember that older theory about depression attributes depression primarily due to the diminished activity of monoamines in various regions of the brain. So remember, your monoamines are neurotransmitters, and they are also your neuromodulator that contains an amino acid group connected to the ring of the chain. And these, your monoamines, monoamines are simply identified as your dopamine, your norepinephrine, and your serotonin. So these neurotransmitters are the amino acid group modulators or neuromodulators. That's why they're called monoamines. So older theory believes that, I would not say older theory because there is just more that's added to the understanding, so it's still a current theory, but it started that the belief is that there's diminished activity of these monoamines, your norepinephrine, serotonin, dopamine, in various regions of the brain, and the lack of which would now determine the mood of a person, the lack of which or the imbalance of which can affect the reaction. And if you remember from earlier discussion, that it actually is, as a neurotransmitter, the responsible in bringing and transmitting reactions from one neurons to the other. So it was believed that the lack of, like for example, the lack of serotonin, the norepinephrine, and dopamine may trigger the feelings of depression because of the lack of stimulation, the lack of excited reaction or motivation that now defines the symptoms of depression. So that's the beginning of the theory, which is until now still being believed, but there is just more add-on to it. So the more contemporary belief now is that the neuropathic hypothesis of depression further suggests that neuroendocrine dysfunction leads to neurospasticity. If you remember, when we talk about neurospasticity, it is the ability of the brain. So the brain has the ability to change its function in response to stimuli. It is also the ability of the brain to change structurally and functionally in response to input from the environment. That's neurospasticity. So if we would say that the contemporary neurotropic hypothesis of depression suggests that there is neuroendocrine dysfunction that leads to these changes, that leads to this neuroplasticity of the brain, that leads to a change in brain function and stimuli. And this is due still to the reduction of monoamine concentration. Well, from before, they would just say that the decrease of monoamine concentration leads to depression. Now we know what leads to the amine reduction or reduction of the amine concentration. It is the change of function due to neurospasticity. And what's the neurospasticity? It is the constant stress. The constant stress becomes a stimuli that if the body is exposed to constant stress, there are changes in function and there are changes in brain, even brain structure and function that leads to amine reduction. And what are the stress? Because the constant exposure to stress elevates the stress hormones. So after all, it's the stress hormones as a reaction to constant stress that actually leads to the change in structure and function of the brain, called the neuroplasticity theory, that reduces the amine concentration. So in a way, it still follows the old theory. There is just more information added now that due to constant stress, it releases chronically, and it resulted to a chronically elevated level of stress hormones, especially cortisol, and these changed the brain function and structure in a process called neuroplasticity, and as a result, there is reduction in amine concentration. This also would lead to dysregulation of brain derived from your neutrophilic factor, or the BDNF. Well, remember, your BDNF acts on certain neurons of the central nervous system and the peripheral nervous system, helping to support survival of existing neurons and encouraging growth. So this constant stress and constant level of cortisol also would lead to the dysregulation of what is needed in order to allow a longer existing survival of an existing neuron, or even growth of a new neurons. So when there is high level of stress and high level of cortisol, there will be problems with the BDNF allowing brain structure change. That's why there will be, less survival of existing neurons, or perhaps there will be less growth of new neurons, which could also contribute to the development of your depression. So those are the different theories behind why there could be dysregulation of your amines or your neurotransmitters that may lead into symptoms of depression. So depression per se is that believe that the patient with chronic and untreated major depressive disorder had lower level of BDNF. That's the reason why with a lower level of BDNF, there might be problem, again, as I've said, with the survival of existing neurons, and there could be problem and dysregulation also of the growth of new neurons. Ultimately, the patient with chronic stress, along with some genetic predisposition, will have elevated glucocorticoids. There will be cellular plasticity. There will be decreased BDNF, and I've explained that earlier. There will be decreased structure and functional process in the hippocampus. Remember, the hippocampus is the one responsible also for your memories, your traumatic memories, So that can be affected also. If you remember, the memory is even the background of your PTSD. Although PTSD brings more about the anxiety, PTSD along with it has some mood problem too. So there's decrease in structural and functional process in the hippocampus, and in major depressive disorder, this may potentiate the cycle of depression, high anxiety, brain changes in function, decrease in BDNF, decrease in new growth of neurons, decrease in surviving of neurons, and so on. So the whole cycle continues. That's why it's so hard to break the cycle. And our goal as a clinician is to find chemical modulators, such as your medications, in the management so that this cycle is broken. So let me go back to one slide. Okay, so we did talk about that cycle. So before medicating a depressed client or medicating depression with commonly used antidepressant, it is also very important to differentiate whether your patient really is experiencing a unipolar depression from being a bipolar depressed. Well, I got to tell you this based on clinical experience. Uh, I would not say, that it is a practice or a common practice, but it's a common observation I have, and I'll take ownership with that, that a lot of patients that comes into a specialized care, such as psychiatry, actually already have been, if not initially, have been assessed and pre-medicated or have been managed partly by the primary care. Because the reality is a lot of mental health, common mental health disorders are being initially screened and managed in primary care setting. Well, the challenge there is that a lot of these patients only would complain depression. They only talk about depression. They only complain when they're depressed, when actually they may have problems with bipolar disorder. Because who would complain about being partying, being so happy, being so excited, multifunctional or multifunctioning in their work and in their home, or they might be having some partying, earning a lot of money, having a lot of friends, not sleeping, and they're all out. A lot of people would even miss that, and they like that, not knowing that it is also a problem called hypomania, if not mania. So they only come into the clinic and complain about how depressed they are. They would expand on the depression because that is not their usual. I'm used to be a happy person. I'm used to be so goal oriented. I'm used to be earning a lot of money. I'm used to be very highly motivated and so on. But then they suddenly drop into being withdrawing, not participating, not even answering the phone. So they only talk about that. Then a lot of clinicians also would listen and believe them. But the problem is they're only listening to one side. So that's why I said that medicating depression or using antidepressant, you got to be very careful that you're actually dealing only with unipolar, because they only talk about how depressed they are. You should not miss even how much they focus on how depressed they are, how much they hate it. Always ask the opposite. Has there been any incidences where you're also the opposite of being depressed? You've been not sleeping. That's number one then, is sleeping is altered right away. The adults sleep 7 to 8 hours on average. Are there nights that you don't sleep, or are there nights when you have problems sleeping, you cannot sleep, you're interrupted, or you don't feel like sleeping? You gotta make sure you expound your assessment, your history taking in that case, because that would uncover some symptoms of hypomania, if not mania, that would now trigger you to look at that. Okay, although the presenting problem as a chief complaint here is depression, there is more to it. So make sure that you differentiate unipolar depression from bipolar disorder, or having depression during bipolar. Well, the reason being, because if you miss that part and you only look at depression, not knowing that that depression is part of the bipolar disorder and you are giving your antidepressant, then it pushes up more to the hypomania. They love it. That is when they would start saying, oh good, your medication starts and it helps. But it does not it does not stay long. After 2-3 months, then they will go so high, and sometimes they love it, sometimes they know that it's just too much, but they're partying, they're usual themselves, and then they reach the sky and drop down depressed. Then that's the reason why a lot of uh, depression, not fully evaluated into even having chances of being bipolar, would probably initially respond, initially is the key word, initially respond to the antidepressant, but it does not sustain. So after a couple of months or weeks even, then they drop down very depressed. What are you going to do? Elevate first, another antidepressant to elevate, and then the same cycle begins until you change to another antidepressant. The same thing, it initially works, it didn't sustain, they drop. Why? Because you're treating depression not knowing whether it's really unipolar or bipolar, and what if they are bipolar. Then it does not sustain. Don't you know that the average, even that goes with the diagnosis, that the average time spent to fully diagnose a bipolar usually average between 8 to 10 years. It's because of this story. It's because patient complains only when they're depressed, and clinician does not overextend their assessment and their history taking to have and to be sure that they have the actual unipolar depression diagnosis, yet treat them right away with antidepressant. And it takes that long. So the cycle begins 8 to 10 years before they're fully diagnosed properly with their differential diagnosis. So I hope it brings you that understanding of before you treat anyone with antidepressant, make sure you are and you differentiate that it's a unipolar versus bipolar disorder. In fact, as I've said there, your complete patient and family history are very critical to your differential diagnosis, and then focus on the presenting problem, which becomes your clinical diagnosis. And I hope you learn from that as a PMH-NP in the future. So unlike most other diagnoses, the goal also of depression is complete remission. So I would like to make sure I reiterate that the new trend right now, that the goal, your goal should be complete remission without relapse or recurrence. That's kind of very, very, I would say daring. That could be very, very daring. That could be very, very assertive of it. But yes, your goal is to have to complete remission. But the reality is this often takes not a single medication to achieve. Remember, the start with the theory there is that there could be reduction of the amines, and the reduction of the amines here is not basically only due to your genetically have decreased amine production, your serotonin, norepinephrine, dopamine. It could also be due to your life, such as constant stress. It decreases your growth of neuron or survival of neuron, or it could even cause the decrease in the production of your amines. That's why, you know, combination. And these amines are your norepinephrine, dopamine, you know, and your serotonin. So it takes sometimes a combination of therapy for patients who are referred to in the psychiatric care. Remission also often is not achieved with the first drug of choice. You got to give yourself some flexibility. Not the first choice that you have always will be result to remission. So there could be some reduction, alteration, adjustments, if not combinations, but you continue into that direction because your it's the complete remission is your goal. So that should be your goal and your outcome. And to be realistic, those are the intervening factor there. That, you know, first choice may not be able to achieve remission. You need to alter, adjust, combine, And it takes, again, a combination um, of some medication, of course, along with therapy, that would actually achieve the longer time of remission, if not full remission. So SSRI is the first line of your treatment. SSRI is the first line of your medication or pharmacological therapy choice. All drugs in this class share the feature of blocking the reuptake transport. Again, we go back to that blocking of the reuptake transport. Remember, whatever is in the synapse or whatever neurotransmitter, serotonin in this case, will be blocked going back to the previous neuron for the MOA, monoamine oxidase, MAO, monoamine oxidase, to reduce or to oxidase and destroy, only to be recycled to make another neurotransmitter. In this case, your SSRI blocks that process, and so there's always constant availability of your serotonin. So all in this class called the SSRI share the same feature. They block the reuptake transport, making serotonin available in the synapse to actually fit into the receptor of the next neuron in order to create that increase of motivation, increase in excitability, increase in enjoyment and pleasure. So then hopefully we control the symptoms of depression. But however, always remember also SSRI in many of this class of medication have unique feature not shared in the class that accounts for variation in response from one drug to another. So although all SSRIs, you have your sertraline, Paxil, Prozac, Celexa, Lexapro, they are all under SSRI category. They may have their own strength, they may have their own weakness. That's why you need, as a clinician, to be familiar with patient's reaction, patient's symptoms, and the characteristic of this medication, because they may have some variation in response from one drug to another. So although we would like to say Prozac is commonly used, but one patient may say, I love Prozac, and the other would probably say, you know what, Prozac, it's not for me. I have more side effects, you know. So, but they have their own characteristic. Also, even so, like Prozac can be more stimulating, but the Paxil, although they belong in your SSRI family, Paxil is more sedating. So those are now the things that you have to mix and match to the symptom manifested by your depressed client. So although they share the same action or action by providing block blocking the reuptake transport, they may have their own unique feature that you have to match, understanding and knowing your patient so that it actually balances out the outcome. So again, this mechanism of action, it blocks the reuptake of serotonin by the presympathetic terminal. Your SSRI increases the amount of serotonin available for neurotransmission. And what's good, as I've said and established before in the discussion during anxiety, is that your SSRI have no direct anticholinergic action. So that's something that we enjoy in your SSRI, that it has no direct anticholinergic action. So primarily advantage is that it lacks the primary advantage of your SSRI is that it lacks cardiovascular effect. So it has less cardiovascular impact to be very concerned of, just like unlike your old antidepressant, your tricyclic antidepressant, your Elavil, the older one that's developed in the 50s, where they have a lot of problems with cardiovascular effect. prolongation of QR interval, and some arrhythmia may happen. So you enjoy, in the SSRI, you enjoy the advantage of lack of cardiovascular effect. Although, as I've mentioned before also, your older antidepressant, tricyclic antidepressant, is very effective in symptoms of depression, but it's also very high side effect, especially cardiovascular. And I've mentioned that before, that what you gain in safety, you lack in efficacy. That is now the problem with your SSRI, because you may not have a very, very high control with depression, although they do. They have safer. They are safer. SSRI are safer. So that's why a lot of clinicians now uses this, because you could adjust the dose, you could combine them, and still enjoy a decrease in cardiovascular side effect. So again, the principle is what you gain in safety, you lack in efficacy. But still, safety comes first. So that's why SSRI becomes your first line of choice. I've mentioned that there is no cholinergic adverse reaction. Also effective for panic, bulimia, and OCD. So your SSRIs are very effective for panic, some eating disorders such as bulimia and OCD. So your patients who may have eating disorder also may suffer from anxiety and depression. So that's an indication of an SSRI. And not only that, they can also modulate the symptoms of your bulimia. And then, of course, your OCD. However, your SSRI is not effective for pain management. That's another limitations of your SSRI. They're not effective for pain management. Unlike you working as a nurse for a long time now, you probably know that a lot of providers also would use some tricyclic medications such as your Elavil, your Elavil, amitriptyline for neuropathic pain, and there are even other classification of antidepressants such as your Cymbalta. They're used for neuropathic pain management, and pain management are using them because they have a good effect in pain management. That is not the case of your SSRI. It is not effective for any pain management, while your old antidepressant tricyclic can be utilized in pain management. So that's one of the limitations of your SSRIs. Selective serotonin reuptake inhibitor dosing. So your Paxil or paroxetine usually has 10 to 80 milligrams per day. Sertraline 50 to 200 milligrams per day. Citalopram 20 to 40 milligrams per day. Citalopram used to be initially approved until 60, but studies and evidence-based practice indicated that there is no further advantage in going higher, and the risk of serotonin syndrome is only intensify greater than 40. So now, more recently, in the past few years, it has been only 20 to 40. Although there are some 10, you could cut it in half, but it doesn't go beyond 40 for, say, citalopram. Escitalopram is a very, very closely related to your citalopram. In fact, some atom they just changed and adjusted, and they call it escitalopram, brand name now Lexapro. Has a dosage of 10 to 20. It doesn't go beyond 20. Your fluoxetine, or the very common popular antidepressant called Prozac, has 20 to 80 milligrams a day, and it can be divided into dose during the day. So those are your dosing when it comes to your common SSRIs. So also another thing you like to remember in considering SSRIs your first line of treatment is that when you prescribe, consider the half-life. Consider the half-life, look at your medication, look at its half-life. Know that a short half-life, so that means it stays on the body shorter, it offers higher control and the use of drug holidays. So therefore, because it does not stay in the body too long, it stays a certain time, and then it decreases. So you have more control over a shorter, because even if you're when you don't give it, it doesn't stay long anyway, so then it's flushed out of the body. So you have more control or tighter control. So you could dose it twice a day or multiple times a day, you know, based, and that's the control you have. So it can also be very helpful to use this concept for drug holiday. So you would say, okay, let's try to rest the body first. Take When was the last time you take this medication? So you take this medication, okay, then it's easier for you to stop because it doesn't stay in the body longer. But the other side of it, the medications that has longer half-life, they are helpful when it comes to adherence. So you have a patient that says, oh, I take it, I forgot it yesterday or 2 days, and I still didn't feel depressed, and then I take it. Because a longer half-life medication, the medication stays on the system, that you don't have to keep dosing it daily, regularly, but it's still able to pick up because it stays longer. They must be less hydrophilic. You know, there must be, you know, this medication that has longer half-life also might be more lipophilic, that stays longer in the body, and it takes a while for it to be flushed out. You know, but remember, because your medication has to be changed into water soluble base that the kidney can flush out. So this medication must be your lipophilic, less hydrophilic. It stays longer. It is good because of when the problem is adherence is the issue. So that's the advantage of that. But you want to know, you know, you want to know also these things in considering which medication you would like to use. For although they belong to the same group called the SSRI, you would like to consider this also in making your decision. And then also consider the sedative property of this medication. Those that are most sedating, meaning you take this SSRIs, remember I initially also mentioned, although they share the same action of prevention of the reuptake process, each medication may have its own uniqueness still. So there are medications that are more sedating, that are more calming, and they're useful in depression characterized by anxiety and insomnia. So if they are the agitated part, the positive symptom of depression, remember positive and negative symptom of depression. The positive symptom of depression, they cannot sleep, they have insomnia, they're pacing, they're anxious, they're agitated, they're irritable, you know. Then the most sedating and the most calming medication can also be chosen for this type of symptoms so that you could match symptoms along with your management. And those that are more activating are useful for hyposomnia. In the other end, if you have a patient that has the negative symptom of depression, withdrawal, sleeping most of the time, 12 hours or more than, they have hyposomnia, they're more lethargic, they have more dragging, they don't have energy, you know, then the more activating one can be used. So if you look at this side picture I have, I put some activating group like your bupropion, although we're talking about SSRI, and there are some sedating medication too. So in the SSRI spectrum of effect, you could look at the activating end and the sedating end. And you have fluoxetine. Prozac is a very activating medication, SSRI. So if I have to use Prozac here, and I know that Prozac is activating, I probably would give this Prozac to patients who are manifesting hyposomnia. 12, 14 hours of sleep, no energy, so tired, just keep staying in bed. While the sedating one, that can make them sleepy, dragging when they take it, and that's paroxetine, I probably would give paroxetine to that patient who is not sleeping, cannot sleep, tossed, torn, no interrupted sleep, early awakening, late going to bed, being anxious also the time. That's why paroxetine is really good with anxiety, because it has sedating and calming effect. So then you could see the picture there. Citalopram and escitalopram seems to be in the middle, and then a little bit in between there is your sertraline, mostly activating, but not like as activating as Prozac. And you have your fluvoxamine, which is your Luvox, and anti-anxiety, good for OCD mostly, but it has some partly sedating, and like paroxetine was very sedating. So this is an example of a diagram that you could mix and match to your patient's symptom. So side effects. Talking about side effects, remember, it is also very important to consider and listen to your patient's complaints of side effects, because as I've said, everyone may have different experience with our medication. Although we know how the action works, they might have their own unique reaction. And this side effect is very important in a clinician to consider, because this may mean compliance to your patient. Well, remember, you only see your patient, and that moment you talk about them, you give them all the education you want, you give them all the expectations, what to expect, how to take the medication, what are the side effects, but then you let them go of them. And then you probably would see them 3 to 4 weeks as a follow-up, but in between there is their compliance. The next time you probably know, the patient says, yeah, it's been a month, but I only took it for 1 week. Why? Because I experienced headache, I experienced nausea. Aside from letting them know what to expect, it's also the severity of these side effects that makes them stop, only to see them later on and they stop it already. So some are CNS activating, other are central nervous system depressants when it comes to side effects. Again, the central nervous system, common side effects, central nervous system that affects the central nervous system is that they can be activating. So people also may experience insomnia, more anxiety, agitation, nervousness, tremors, dizziness. That can be as an activating side effect, or a sedating, somnolence and fatigue. It makes them so tired, it makes them groggy, it makes them dragging, and they're so sleepy, and they cannot function at work. You will hear this all the time. So always be mindful, always be able to give them anticipatory guidance that they will be able to notice it. Most of the side effects that are minor may be there the first week or so, week or two. After 1 week, it starts to be relieved, or it starts to go away. Tell them that, so that they at least go over the hump, and they will be able to cooperate more with their compliance. Akathisia, or muscular movements, EPS, inability to sit still, can also be expected. Some of SSRI may have ringing of the ear. We'll tell them if that doesn't improve, then we probably have to stop that medication. Headache, they come early in the first time they take the medication, first few days, first week. They're very, very common. They could take Tylenol with it, and they go away after a week. Okay. There are also some others, such as GI side effects, nausea, vomiting, abdominal pain, diarrhea, constipation, dry mouth. They can improve, and they will go away after a week or so. Remind them then, so that they know what to expect, and they cooperate until they will start to get the therapeutic effect. If you have to decrease, then another way of going around and allowing the body to adjust, although they may develop these side effects, they should start to improve after a week or two. But if they start to linger on, and it's just dragging with the side effects, it's been 3 weeks, 4 weeks, you follow them up, they're still there, it has some improvement, then you probably would like to decrease the dose, rather than asking them to stop it. So the approach could be, you may have to, okay, you start them with 20 of Celexa. After 2-3 weeks, there's still some side effect, it's improved but still lingering. You probably want to back down to, okay, before we stop, let's try about 3 weeks, or 3 weeks or 2 weeks more of 10 milligrams. You are decreasing the dose, not necessarily stopping it, allowing the body to adjust and see now enough time, about 3 to 4 weeks of having been on the medication, although the last 2-3 weeks you adjust and lower it down, then side effects are more controlled. Then you will say, okay, let's try to bump it up back again to see the effect. So don't just right away, unless it's very compelling, life-threatening, to say let's just stop it and then change it. Some patient would stop it already. That gives them really the trial and error kind of approach, and it's hard because you need to start another medication and wait for another 3 to 4 weeks. In this case, if you try the principle of let's back off, decrease the dose, then encourage them to stop taking the medication and then go back to it slowly, could be a better approach. So instead of then it's done, encourage to stop the medication. Not then, it's done. Sexual dysfunction, as I've mentioned before, example of a sexual dysfunction can be loss of libido, impotence, dysorgasmia, difficulty of climaxing or attainment of orgasm, or some in male, even some retrograde ejaculation can happen. The same approach, decrease them, give some time, and then slowly increase rather than just stopping it right away. Weight gain is also very, very common, even with SSRI, although it has less, meaning when we say less weight gain, they may have some weight gain. It varies from medication to medication, but there's an average weight gain. Like they will probably have an average of 5 pounds or 6 pounds, but it does not keep going. So you could remind them to be realistic. Weight gain is very potential in any of this classification. Although in this medication, weight gain would average to this average weight. It doesn't mean that you keep gaining as you go month to month to month. Yes, there are weight gain. There are things you could do. So we have to look at risk versus benefit. So that's one way also of educating your patient and talking to them in a personal note. Although their weight gain, to be realistic, you would say, although their weight gain, it usually average up to this weight, 3 pounds, 4 pounds. It depends on the medication. Look at the literature, but it does not keep going. So what are the things you could do? You could increase your activities, and make sure when you do your health teaching, increasing activities, some of them and a lot of them would say, yeah, I already have increased activity at work. No, remember, the definition of increased activity is above and beyond your routine. So if your work allows you to be on your feet all the time, it's not above and beyond. It is your work. So you have to go an extra effort, more than just standing and walking at work, to achieve an above and beyond or extra activity. So you have to be in times of when you're done, then you still have to walk, then you still have to run, then you still have to go to the gym. That is the responsibility. Quality and quantity of food also can also help to counteract weight gain. What's unique with the weight gain here is that SSRI is very known also to initially have some weight loss. They tend to like it, and it's good because for people who's very sensitive to weight gain, that's a good indication, but also be very realistic in telling them. But this weight loss can be initial. There could be a followed weight gain, but on the other end, the followed weight gain may have reached its average weight gain. Then you have to do your part, such as increasing activity and watching your food, both quality and quantity. So those are things that you want to consider. Side effects when SSRI are abruptly stopped. Stopping formulation with a half-life of less than any formulation with a half-life of less than 24 hours may cause withdrawal symptoms. which may be mistaken with a recurrence of depression. So those are just the withdrawal symptoms. If especially those formulation that has a formulation that's half-life less than 24 hours. So make sure also you consider this and let them know. So it's not good to abruptly stop, but rather taper it down. Serotonin syndrome is the greatest risk, especially patient who's on greater than one serotologic drug. Now, I would say greater than one serotologic drug, we're not only talking about SSRI. You don't usually want to give two of the same class because of serotonin syndrome. And the risk also for your hypertension. You know, hypertension as one of the manifestation of your serotonin syndrome. But I'm also looking at SSRI that can be combined with other SNRI. So although they are having some norepinephrine, they still have some blocking of the serotonin reuptake. So you could look at here like Celexa along with Effexor. Effexor is an SNRI. You know, they scan. You know, this can increase the potential for serotonin syndrome. So you make sure you let the patient know about intense headache, monitor the blood pressure, if not get the baseline because of your serotonin syndrome risk. SNRI, SSRI, TCA, MAO inhibitor, triptans. So when we say triptans, they are your medication for migraine. Also used for cluster headache. You have your tramadol, which is for your pain and muscle pain. Meperidine, that's your blood pressure medication. Dextromethamphetamine, or your lenosides. Linozolid medication are some sort of group of antibiotic. This can also increase possibility when combined with SSRIs can increase serotonin syndrome. So consider holding other serotonin forms of medication to prevent serotonin syndrome possibility. I would like you also to review at this time what are your symptoms of serotonin syndrome. Serotonin syndrome, most do not get full-blown psychosis, but they will have some confusion, agitation. Milder forms can be agitated. They may experience jitter, tremors, as I've said, increased blood pressure, pulse, diarrhea, but mostly do not get full-blown psychosis. They may have some, as I've said, agitation, probably some confusion. As their initial symptoms of serotonin syndrome. So we just want to make sure you let the patient know, or you monitor patient who is on other type of medication that may enhance or any other type that would increase serotonin more. One thing I have to mention, MAO inhibitors should be defined as not to be given with SSRI. You need to have at least 3 weeks of lapse time before giving one of each class. So if your patient is on MAO inhibitors, you need to wait 3 weeks before initiating an serotonin base or SSRI kind of thing. And SSRI, if they're on SSRI and there's a need to go into MAO inhibitors, you need to have 3 weeks in between. Otherwise, there's a very high risk for serotonin syndrome to happen, and you don't want that to your patient. Other drug interaction with your SSRIs, the heterocyclics, they will increase the levels of serotonin. Warfarin, patient who's also in warfarins may have, it potentiates bleeding more. Patient with on tamoxifen along with SSRI, they reduces the efficacy. So always consider CYP 450 interactions with your SSRI. So what's CYP 450? You remember again in our biologic basis and your psychodynamic discussion, that is actually uh, your genes that is responsible in degrading your medication so that it can make it more readily excretable. So consider CYP 450 interaction as this medication combined with SSRI makes it fastly remove, then it makes it less effective, or if it slows down CYP 450 activity, then it may cause a buildup of metabolites and increasing the side effects. So consider CYP 450 interaction along with the use of SSRI. For example, your paroxetine and fluoxetine has the greatest CYP 450 interaction potential. Okay, so they allow an interaction between the two, allowing them to be removed from the body faster. So you probably would like to adjust the dosing here. So unique SSRI feature such as your fluoxetine, they have unique serotonin antagonist property. Your fluoxetine, they have agonist property. So that's the reason why it becomes activating. Your fluoxetine mixed with other medication that has an SSRI kind of thing, it has an agonist property, so it enhances more the effect of serotonin with another serotonin modulating medication. So that's why they are more activating. So they will increase more of their awareness, agitation, alertness also, you know. So that's the reason why there are medications that are combined with your fluoxetine, such as your olanzapine mixed with fluoxetine, because the fluoxetine can have an agonist property to the medication called olanzapine. Olanzapine is an atypical antipsychotic, you know, so it can also enhance fluoxetine as a agonist can enhance the antipsychotic effect. So they could be more alert, and thus it decreases the symptoms also of psychosis. So olanzapine mixed with fluoxetine basically has a brand name called Symbyax, Symbyax. It is actually olanzapine mixed with Prozac. So what's unique is that it has the combination olanzapine Symbyax along with fluoxetine has a long half-life, and thus it's available as once a week dosing. Even Prozac in itself, don't you know that there is a Prozac once a week? Because it can have a markedly long half-life, plus the component of the preparation of a slow releasing, they could have once a dose Prozac. And I have a couple of patients who's only taking Prozac once a week. There's a long-acting Prozac once a week dosing because it has a long half-life. So sertraline, what's unique with sertraline, by the way? So we're talking about certain unique feature. First is your fluoxetine. It's a good agonist. It's activating, and it can have a long half-life. That's Prozac, fluoxetine. It's a unique feature of fluoxetine. So this time we'll talk about what's unique feature of an SSRI, focusing on your sertraline. There's two uniqueness with sertraline. It can have dopamine transport inhibition, and it has a good sigma-1 receptor binding. As a result, this produces activation in patient with low energy. So your sertraline is good as your patient who has low energy, and usually also sertraline can do well when combined with bupropion or your Wellbutrin. And sertraline as an antidepressant is more helpful with depression that has some psychotic feature. So that's one consideration of a unique feature of your sertraline. It is helpful with depression that has some psychotic features. So sertraline might be your drug to go to. And it is good also for patient with low energy. And if you want to combine it with bropopion, when do you want to combine it with bropopion? Because, you know, they may have increased, or they may have some advantage in controlling symptoms, but it doesn't totally obliterate. So you're looking at having some SNRI that has influence with norepinephrine and bropopion with that. A good example would be patient on SSRI probably lost some or experienced sexual side effects, loss of libido, loss of interest, loss of function, cannot ejaculate. Then I would usually add Wellbutrin along with that side effect of SSRI, because Wellbutrin or bupropion is activating also. Then it could enhance. The problem here is that if you already have a patient that has anxiety, agitated, pacing, mixing it up with bupropion would not be a good idea. It would increase more of the agitation, and probably you don't want the sertraline to use because of it can also make them agitated, and it could make it more anxiety. So you want to have more of those calming effect, such as your Paxil kind of thing effects. I mean, escitalopram or citalopram can be in the middle. A unique feature of paroxetine, commonly known as Paxil, it has some that you need to consider because it has some anticholinergic and your norepinephrine transport inhibition function. So it can have norepinephrine inhibition transport function. So this is useful. Your paroxetine is useful when anxiety is a strong component of the symptom. In fact, paroxetine, I've noticed it down. If they're more anxious with some depression, then you probably would like to use your paroxetine. But a particular concern is about rebound when you withdraw them suddenly. So they will probably go into depression if you withdraw them right away. So you want to make sure you taper them slowly. Okay. This is probably the reason why paroxetine is more sedating, because again of the norepinephrine transport inhibition. It inhibits transport of your norepinephrine, and you know that your norepinephrine can also be stimulating. So that's why the use of paroxetine, as it inhibits its transport or norepinephrine, can be very sedating. So that's why they're also sleeping. So you want to make sure you use that appropriately based on your patient's symptoms. Fluvoxamine, although not identified as antidepressant, fluvoxamine as an SSRI is very good indication for your high anxiety. This is your Luvox. It's like your OCD, used primarily for OCD symptoms, obsessive compulsive disorder symptoms. That's why, because they control your anxiety and it decreases anxiety. That's why they're good for OCD. Your Buspar is basically good for generalized anxiety disorder, but your fluvoxamine is what's really, really good with OCD, if not your paroxetine. And your Luvox, also, or Luvoxamine, is good indicated for your social anxiety. So those are some good features that you will review when you come to your prescribing of medication. Citalopram or your Celexa. Well, they always say, and officially, you know, that the advent of SSRI in the 80s, mid-80s, early 90s is very, very promising. Aside from it does control depression, although not as intense control like your older one, your tricyclic, but it does control anxiety and depression, hitting two birds in one stone. the best approach, I mean, the best advantage here is that it is very safe, you know. So citalopram, it always been said that in the 80s they developed Prozac. Side effects of Prozac is still there, such as agitation, perhaps some weight gain, you know. They improve the molecule and developed citalopram in the 90s. And then later on, late 90s to early 2000, they developed citalopram and make it better and develop e-citalopram. That's why you have Lexapro. So unique feature of your citalopram or Celexa, they have mild antihistamine properties. So they have mild antihistamine properties. Remember, your antihistamine suppresses so it suppresses histamine-induced response, such as swelling, or your vasodilation, or your flare response. And they do this by blocking and binding of the histamine to its receptor, or reducing histamine receptor activity on the nerves, on the vascular smooth muscle, in your glandular cell, endothelium, and in your mast cell. So they have mild antihistamine properties. They are well tolerated in elderly, so you may probably would like to choose this among elderly. The problem or the concern here is that it can have an inconsistent response in lower dose. I mean, if this is the very first time your patient has tried any anti-medication, you probably would like to do a lower dose. But be in mind that after you follow up in 3 to 4 weeks, then you will have to adjust, because it does not sustain its result really well in lower dose. So you might probably start with 10, and then after 1 week or after 1 month go to 20. At least you will be in the lower recommended dose of 20. Because lower than that, probably 10 or 5, they have a very inconsistent response. There are some concern with QT prolongation, though, in high doses. And that's the reason why they have to review it. Recommending with a higher dose of 60 is no longer, because of QT prolongation and less efficacy on a higher dose, but higher QT prolongation in higher dose. So it's only given between 10 to 40, no beyond 40. So, but be concerned also with QT prolongation in higher dose. So you might want to have a good cardio, at least EKG baseline. And then, as I've said, you know, citalopram, they develop more and change some of the compound and molecular properties, and created e-citalopram, brand name Lexapro. Unlike your Celexa that has mild antihistamine properties, there is no antihistamine properties for your Lexapro. So they're calling it, in layman's terms, there's more pure. The challenge, though, is that e-citalopram, you cannot go beyond 20. It's only 10 or 20. So you're very, very limited. Hopefully you get the result and you get a good response between 10 to 20, because you cannot go beyond 20 here in this medication. But it's more purer, I would say. There's no antihistamine properties. So dry mouth is less, you know, no QT prolongation, unlike your Celexa that in a higher dose, it has QT prolongation. No CYP450 interaction, so it doesn't interact, doesn't slow down or enhance its metabolism and its excretion when it comes to your CYP450 action, because it doesn't have too much interaction. So it's predictable. It's more stable. Consider best tolerated SSRI because of those advantages. You just have limited dosing. And then lower dose usually is effective. And what's lower dose here? 10. You could break 10 in half. Then you could have 5, but you cannot go beyond 20. So lower doses usually is effective. That's why it stays up to 20 milligrams only. Then we have your serotonin partial agonists, reuptake inhibitors. So these are newer medication now. They still are a serotonin partial agonists. That means they enhance, but they don't fully enhance the effect of serotonin. They can partly, and then it's also reuptake inhibitor. So they enhance moving forward the serotonin effect, but they are also preventing the total destruction at the end. So these are your Vibrad and Trintellix. So these are, as I've said, the newest class of antidepressant. In addition to the classic SSRI property, so it has the SSRI property having its agonist effect, although it's partial agonist. Um, it acts as an agonist at the postsynaptic at your serotonin receptor. So it does enhance partly the attachment in the receptor, and it prevents reuptake in the synapse area. So it prevents the destruction, yet it partially, not fully, enhance affinity to the receptor site and to create its physiologic effect. Action has been achieved with combination therapies in the past. Uh, so in the past, when it was new, Vibrad and Trintellix is best added on with some common SSRIs, your Celexa, Paxil, your Prozacs. They can, but now is available as a single agent. So now, recently, your Vibrad, your Trintellix are available now as a standalone monotherapy. But it was recommended earlier on as an adjunct or as an add-on at a combination. But now it's available and is recommended that it can be used as its individual. Common side effects I've noticed it in clinical practice is dry mouth and nausea. So you gotta watch your patient and inform them way ahead, especially that of Vibrad. Okay, especially that of Vibrad. They go away, but a lot of patient complains of intense nausea. Another thing too with your Vibrad and Trintellix, they are not generic yet, so you may come across with insurance limitation of coverage. Otherwise, it can be very expensive. Advantage also, what I've noticed, and I do agree with what the literature is saying, your Trintellix and your Vibrad has a lesser incidence of sexual side effect as compared to SSRIs. So if you have a patient who's an SSRI and then they complain because they could be young, they could be newly married, new couple, together, and they are on antidepressant, although it helps with the antidepressant, but it also interfere with their sexual intimacy because of the side effect, then your SPARIs, your serotonin partial agonists, reuptake inhibitors can be a choice. So this could be a choice that you could anticipate to add on or change and switch. It has a more rapid action due to serotonin agonism that leads to higher GI effect profile. That's one of the limitation to it. There's a higher GI effect profile of as a result of this, and that's why I said I even see it in clinically that I have a lot of patient that stops. There's a compliance issue because of severe nausea and vomiting actually. You have your SNRIs, and these are your serotonin norepinephrine reuptake inhibitors. Mechanism of action is that they increase serotonin and norepinephrine at the synapse. So it's both serotonin and norepinephrine in the synapse. Remember, as I've said before, there is still serotonin component. So if you mix this medication with your SSRIs alone, your sertraline, your Prozac, your Celexa, your Lexapro, make sure you monitor symptoms of serotonin syndrome because it has serotonin effect still. They increase downstream dopamine at the prefrontal cortex. So they also affect your dopamine. And norepinephrine reuptake inhibition is believed to contribute to control of both depression and neuropathic pain. So these are the medication as NRI that can also help both in depression and in neuropathic pain. In my practice, I am PMHNP, although I have also adult and geriatric, but I focus on psychiatric. So I can complement. I would always tell my patient, if you have a lot of patients who are in chronic pain, back pain, nerve pain, and they're saying neurologist or pain medication, but the effect also is depression. So I always would say, I think it is my choice, after I can give you an antidepressant that can ultimately have some effect to your pain, but you always have to see your neurologist, if not your pain medication doctor. But I will recommend also SNRI such as Cymbalta because it can have some effect of your pain. So then, but make sure you have to refer them, because if you're not certified on both, then you should stay on your population focus. But that's an advantage, hitting two birds in one stone. Mechanism of action generally regarded as a second line agent for patients unresponsive to or intolerant to SSRI. You don't want to jump right to SNRI right away. A lot of primary healthcare goes to SNRI just because they have heard, they have familiar, some MedRep went to them, but a good decision making is that make sure you try them on SSRIs, a couple, before you go to SNRI or before combining it with SNRI. But again, so there are more patients or more providers who are more exposed to or more experienced to. They may be in initial appropriate drug depending upon the comorbidities and symptoms of presentation. So make sure you have a really good history taking and you have a good assessment. What are their medication and what do you target if you would like to go SNRI initially rather than the first line, which is SSRI. So dosing of your SNRI, you have your venlafaxine or Effexor. You have 75 up to 300 milligram per day. Duloxetine, and that is your Cymbalta, and it's very good also with some neuropathic pain. 20 to 60. I've even seen a newer indication of your duloxetine up to 90 and 120. Yes, as a duloxetine. You have your this venlafaxine. It's called Prestige. So again, very closely related to your Effexor XR or venlafaxine ER. But this one here is your Prestige. And then you have your levomelnazepran and 40 to 20, and that's generic name Fitzima. That is a newer medication also, but it is an SNRI called Fitzima. All SNRI need to be titrated. Always remember, they create really, really bad side effects and withdrawal, including headache. I have heard a lot of people complaining of zaps in the brain, headache when they stop it abruptly. So you make sure you titrate it down over at least 4 weeks period. Do it very slowly. Like your Effexor, they may come in 75 and there's a 37.5. So use it, cutting it in half along the way every week. So probably if you start with 150, then you would start into 75 and then 3 or into 35, 37.5. Or even to patients who are very sensitive from 150, you would probably have go down 37.5 at a week time. Can be also very appropriate in titration. But make sure you titrate them down at least 4 weeks period. Venlafaxine ER tablet are bioequivalent to effects or ER, so they can be in change. So what do we mean by bioequivalent? So that means if you have venlafaxine ER 150 and you could change it to effects or XR 150. Capsules about 80% of the cost, and they are bioequivalent. You could just exchange them, but your venlafaxine are much cheaper because they come now in generic. Your brand name is your Effexor XR. Adverse reaction to your SNRI is similar to your SSRIs. And then just monitor, because with a norepinephrine, it can increase the blood pressure. Especially the higher dose you go, make sure you get the baseline of blood pressure and monitor blood pressure and ask the patient to check their blood pressure. Your bupropion is under your NDR, your norepinephrine dopamine reuptake inhibitor. So they don't have much of your serotonin influence. So that's why if I have to go and influence norepinephrine and dopamine, because probably the symptom serotonin has helped, but it didn't fully relieve the depression, or there are some other symptoms also, that lack of energy, and you want to perk them up a little bit, lack of excitability, they don't feel blue down deep, but they still feel fatigue. You want to enhance that with a more stimulant and stimulating effect of an antidepressant. Then you're thinking about norepinephrine and dopamine. I usually combine them with SSRI so that I don't have too much risk of serotonin syndrome, because your Wellbutrin is an NDRI, norepinephrine dopamine reuptake inhibition. So there is less component of serotonin to worry about serotonin syndrome. So as the name implies, it inhibits reuptake of norepinephrine and dopamine. And although the mechanism of action is unclear, but it's also very helpful to enhance that symptoms of depression, such as fatigue all the time, lack of energy, feeling tired, or I could even use, because of the dopamine effect, the excitability when it comes to sexual side effect, especially loss of sexual interests or loss of the sexual function. Then I could combine them with lower dose of Wellbutrin for its dopamine excitability, and then it usually would perk up their sexual arousal. I do have that experience. Again, I have a lot of experience, but just more recently of a patient who's having depression, and he has also actually bipolar, and I've used Abilify, which is indicated also for depression type of bipolar. Can be depression but has some mood problem along the way, or bipolarism symptoms or history. He was doing really well. He was usually agitated, but then that symptom has gone. Hypomania is controlled, depression is controlled. They live very, very comfortably. But into 3-4 months, he noticed that they don't have intimacy with a wife or with a partner. So he complains. I mean, not complained. He brought it up. So I said, well, he says, but I'm not willing to give it up, the medication, because it has helped me a lot, both at work and at home. My mood is stable. I'm not angry. I'm not agitated. I'm not depressed like I was isolating before. So the medication has really helped. The Abilify has really helped. However, I just realized that I don't have intimacy with my wife for the past 3-4 months now. So then I did last month, I put him on Wellbutrin because of the dopamine effect of it. And then I've seen him like 3 days ago, and he says, well, Dr. Tan, it did a trick. So I did have some intimate activities, relationship with my wife again. Now that I'm on medication and I'm not so excited, I'm not so hypomanic, I'm not agitated, I think the 75 milligrams of your Wellbutrin, which is the lowest dose, help me out. So that's good. So that's where the advantage of combining medication. So its actual mechanism of action is still unclear. It is also successful in smoking cessation. A lot of patients goes to the clinic and ask for, can I have some medication for smoking cessation? It is not psychiatry. Okay, make sure you know, although there are medications we use in psychiatry that can decrease cessation, unless you are trained, then do so. The State Board of Nursing is going to ask you, if you do and there's a problem, usually you will not be penalized for doing so. You get penalized when there is a problem or there's a complaint. And then they will ask you, if that would happen, is that, do you have the training? Well, if you do, why not? But most of your PMHS NP does not include smoking cessation as a modality of care, unless, as I've said, after you get your certificate, you go into training and then you make sure you document that, then you may. But most of the time, if they come to you, ask for smoking cessation, refer them to their primary care. Primary care, the smoking cessation, and they use such as Wellbutrin, to do, or Chantix. Chantix is very closely related to Wellbutrin, but it's not a psychiatric medication. It's smoking cessation used mostly by primary care. So Chantix has the same kind of action, but it's not psychiatrically usually used unless under specific training, but it acts mostly close to Bupropion, and they are used successfully for smoking cessation. I treat them, if they have problems smoking, I treat them for the anxiety and the depression using NDRI, letting them know that it may have an effect with your smoking, but that is not what I'm giving it you for. Because I'm not trained for smoking cessation. But it can have a successful smoking cessation properties, because it can inhibit craving and compulsion and the urge to do smoking or act of smoking. Again, your Wellbutrin or Bupropion is both activating and stimulating. It has markedly lesser sexual side effects. As I've said, it can enhance. Also, weight gain is an advantage here, because your Bupropion is the only antidepressant that has indication of weight loss, or if not, that does not increase weight anymore. There are some atypical antidepressant, meaning they have antidepressant effect, but they are not commonly used, and they are your mirtazapine or your Remeron. It enhances noradrenergic and serotonergic release by blocking presynaptic alpha-2 receptor, and does not inhibit the reuptake. So it can stimulate your noradrenergic and serotonergic by blocking the synaptic alpha receptor by the receptor side, but it does not inhibit reuptake. So it's the receptor that they actually would enhance rather than the destruction. Mirtazapine can better be also used as an anxiolytic, and the advantage here, it has lesser sexual side effects and lesser sexual profile. What I found out with mirtazapine is helpful because it has sedating effect, and it can help with problems of sleeping pattern disturbance among depressed individual. So that's why we could give it also at night or as a PRN to induce sleep and sedation, to promote sleep without using a controlled substance. Then you have your monoamine modulator. Remember, if I have to bring you back to the concept of monoamine oxidase, they are enzymes. They're actually enzymes that's in the neuron that's responsible in the reuptake process of breaking down the serotonin after the process of reuptake, so that they will be able to use it to cycle back and use it to recycle the production of serotonin or your other neurotransmitters. So, so your monoamine modulator in this case helps, which actually helps facilitate amine synthesis. So remember, your monoamine oxidase are the enzyme that breaks it down, and then as a result the serotonin is being broken down, and then it's synthesized back to, as it breaks down the serotonin, it is recycled to be used and produce new serotonin. This monoamine modulator helps and facilitates amine synthesis. So after it's broken down by monoamine oxidase, the amine, it facilitates the production and synthesis of another amine, such as your serotonin and other neurotransmitter. This is marketed in the US as Deplin. It theoretically makes patient more responsive to antidepressant also. So let me spend a little time. You may probably hear me talk about this again, the Deplin, as it facilitates amine synthesis after it was broken down, after the neurotransmitter is broken down by your monoamine oxidase. Okay, I'll go back to that monoamine oxidase later on. But as it breaks down the neurotransmitter, especially serotonin, norepinephrine and dopamine, but mostly serotonin also, this type of medication facilitates production of another new amine in the process of synthesizing a new one. So how does it do it? I would like to remind you of folate, okay? Think about folate. Folate is the synthetic form of your the element called folate. Folate is that elements you gain from green leafy vegetable, and probably a lot of pregnant women take folate because it's needed for the RBC. While the growing fetus is developing, you need to have good oxygenation, good RBC. Anyway, so that's folate. Synthetic form of it is folic acid, that what you can buy in Costco. Anyway, I would like to focus on this discussion to that really briefly. Folic acid is your medication that actually needed to develop your RBC and some other component, one of which too is also responsible in the amine synthesis. Where in the amine synthesis? But your folic acid or folate, your body cannot is unable to process it. Your body doesn't know how to process it because it's complex. Just like your carbohydrates. Your carbohydrate is so complex for your body to process it, but with the presence of enzyme in your saliva, called your enzyme in the saliva, can simplify your carbohydrates, your cake, your rice, your bread, and simplify it into an absorbable form called glucose. It is now the glucose, a simplified form of your carbohydrates, simplified by your enzymes, that can be absorbed by the cell and used as an energy. So I give you that as an example. It's the same with folic and folic acid. Folate or folic acid as its synthetic form, your body don't know how to use it. However, once you digest the folic acid or folate, you have a gene called your MTFHR. MTFHR releases an enzyme called MTFHR. That MTFHR enzyme is the one that's responsible in simplifying your folate to its simpler form, like your glucose from carbohydrates. In this case, MTFHR can simplify your folate or folic acid into L-methylfolate. L-methylfolate now is the simplest form coming from your folic acid that your body knows how to absorb and utilize. So it's needed that you need to have your MTFHR enzyme to convert folic acid to L-methylfolate. Now, this L-methylfolate is the one that is needed for amine synthesis. So your Deplin is an L-methylfolate now that actually makes it readily available so that you will have L-methylfolate in the production of amine synthesis, and part of which coming from the destroyed serotonin or destroyed dopamine and norepinephrine in the process of reuptake. So in the whatever the component there is in amine synthesis, we need the L-methylfolate so that it enhances more production of your serotonin and other neurotransmitter. That's where it can make now the antidepressant effect. That with the supplement L-methylfolate or Deplin, it is now helpful for your antidepressant properties. So if you are an antidepressant, you don't need to keep increasing because you're allowing the body, its component, to produce and synthesize its own amine, so that you don't need to keep increasing your exogenous antidepressant. Hope it helps. Tricyclics are your older form of your antidepressant. Mechanism of action is that it blocks the reuptake of norepinephrine and serotonin by your presynaptic terminal. So it is a potent muscarinic antagonist. So what do we mean by muscarinic antagonist? This is also known as your anticholinergic agent. So both your tricyclic are muscarinic antagonist, also known as your anticholinergic agent. They are effective bronchodilators, as an anticholinergic agent. They are effective bronchodilators. They use in treatment of COPDs. They're used to alleviate dyspnea and improve exercise tolerance. So as an muscarinic antagonist, it reduces the activation of your parasympathetic nervous system. So it reduces the activation. So you know that in the heart, the parasympathetic slows down. Okay, so the normal function of parasympathetic is often summarized as rest and digest. So where's the rest and digest here? What slows down the heart is the rest. It includes slowing the heart rate. But what slows down the heart in your parasympathetic, it's increase the activity of the GI. So that's why it's called rest and digest. It rests the heart, it slows down the heart, but it increases the rate of digestion. It also promotes urination and sexual arousal. That's your muscarinic agonist. Your muscarinic agonist counters this this rest and digest response. Your tricyclic is a weak alpha receptor agonist, and it's a weak histamine antagonist. So what are these heterocyclic medication? Your tricyclics are their old medication. These are now the one that has been developed even in the 50s. They are your imipramine, tofranil, amitriptyline, Elavil, doxepin, Senequan, and your trimeptaprine, Sormontel. Honestly, I haven't ordered Sormontel. Brand name, Torfanil, Elavil, Senequan, I have given them as a nurse. I have not ordered them as an NP. I have, however, with Elavil. I have, however, with Elavil. And I have a very, very, very striking experience knowing that it has a muscarinic antagonist effect. I'm very, very careful about urinary retention. I do have a patient that has been very resistant to my SSRI, SNRI combination that I decided to try tricyclic. Again, remember, they're very, very good with depression symptoms, but they are highly having problems with side effects. But I bite my bullet after trying first line, second line combination of. So I tried tricyclic and I tried Elavil. I'm very, very careful. I start very, very low of 25 milligrams. I mean, it can go 100, 150, you know, it can go really high. But I start with 25. Lo and behold, in 2 weeks' time, the patient developed retention, urinary retention. So I stop it right away. So that's just safety versus efficacy. Who knows? It might be very efficacious for the patient, but it just didn't get time because the patient developed the side effect of urinary retention right away. So I stopped it. Side effect, it has anticholinergic effect. Dry mouth, constipation, urinary retention. And that's what I have experienced with this patient. Blurred vision, heart block, so that's why high safety risk, especially cardiac risk profile, and slow gastric emptying. It can also create orthostatic hypotension, some tachycardia, sedation, drowsiness, and central nervous system hyperactivity. So that makes the patient having lower seizure threshold. So that's why if you have a patient that can also have some seizure problem, this medication can also enhance. So you got to be very careful. That's the reason why, because of its side effect risk, it is contraindicated for patients who have acute recovery from MI. So you got to make sure you take patient's history well. Heart blocks or conduction blocks. You know, you got to make sure you check patient's EKG prior to starting this medication. And those patients who may have severe hepatic and renal impairment. So before starting this medication, you may probably would like to have a baseline also of your blood work, your liver profile, your renal profile also. And you need also, because of safety issue of this medication, you need to monitor your blood works, your complete blood count. This may also increase blood glucose, and then it may falsely increase your urinary catecholamines. Then we go to your monoamine oxidase. Now this is a time I have to assert back. Monoamine oxidase are the enzymes. They are enzymes in the mitochondrial of the cell in your axon that is responsible to destroy or damage your amines or your neurotransmitters, specifically your norepinephrine, dopamine, and your serotonin. They're the one who would destroy back when they go back in the process of reuptake in the axon, so that they can be recycled and used to develop and synthesize newer amines. Okay, so this is your monoamine oxidase. So your medication monoamine oxidase inhibitor inhibits, the mechanism of action here is that it inhibits the release of your mitochondrial enzyme. So as a result, it inhibits the oxidation of your monoamine, of the monoamines, such your norepinephrine, serotonin, and your dopamine. So it inhibits the destruction and the oxidation. So that's why there will be still have some increase in your amines or your monoamines, such as your serotonin. That's why it's not good for this medication to be given with SSRI. You need to have 3 weeks in between, because this can increase markedly your hypertensive crisis, and this monoamine or MAO inhibitors if mixed within that 3 weeks period with as SSRI, can increase the risk for serotonin syndrome, which is very, very, it could be fatal. Okay. So the antidepressant effect here is due to the inhibition of MAO to destroy your serotonin and other monoamines, making it having still some of the amines available for forward transmission. So what are examples of these MAO inhibitors? You have your Marplan, Nardil-Parnate, Emsams. So honestly, it's still available in the market, but it's less utilized because of its risk profile. Side effects basically is due to CNS stimulation, hypertension, and cardiac dysrhythmia. So you need to monitor patients for this. Side effects, there's very strong anticholinergic effect described previously. I described previously already your dry mouth, urinary retention, blurred vision. This is due to the imbalance between monoamines and acetylcholine. This is contraindicated for conditions such as your phochromocytoma. What is the condition of phochromocytoma? This is when you have too much of your catecholamines, such as your epinephrine, norepinephrine, and dopamine. Okay, that can increase your perspiration, palpitation, hypertension. That's your phochromocytoma condition. So that's contraindicated. So therefore, it's contraindicated if you do have some potential adrenaline tumor, because in the adrenaline tumor, especially in your adrenaline in the adrenal medulla, can release increase of catecholamines, neurotransmitter, your epinephrine. It's also contraindicated in CHF. So cautious use in patients who are hypertensive or who are hypertensive, dysrhythmic, and epilepsy, because it can decrease the seizure threshold. Food interaction, very important, and you watch and tell your patient about this. These are contraindicated to be used with food that are aged. So aged cheese, red wine, beer, on the process of food that are aged. So this is very important that you should not, because why? The problem is it can create hypertensive crisis. There are drug interaction, especially with your antidepressant, your heterocyclic antidepressant, your tricyclic antidepressant. This is contraindicated. Also contraindicated, or there are some drug interactions when it comes to levodopa, alcohol use, and your meperidine. So for those unresponsive for antidepressant, or unresponsive or poorly responsive to 2 drug attempts, always consider this. Reconsider your diagnosis. Did you have enough time to spend in talking? Are you looking at only depression, or perhaps you miss the hypomania and the mania? Because remember, in diagnosing your depression, your bipolar, it says 1 or 2 moments of hypomania and mania in a lifetime. And that could easily be forgotten, or they could not look at it and you forget to ask about it. So if you fail on antidepressant and is responsive with 1 or 2, or it does not sustain its effect, it may have effect a little bit, but it doesn't sustain, reconsider your diagnosis. Could it be a problem of unipolar alone or bipolar? Unipolar depression or bipolar, having mania and depression. So expand from the antidepressant spectrum 2 is another thing. So aside from SSRI, SNRI, then probably there are other atypical medication you could use. So look at back again after 2 attempts of medication that is unsuccessful, that is not sustaining. Also remember that patients with bipolar disorder are started on antidepressant and may demonstrate exacerbation of symptoms later on. Therefore, ensure diagnosis of unipolar depression before beginning antidepressant therapy. You got to be very careful with your assessment and your history taking to make sure that you zeroed in a very strong evidence for your differential diagnosis. For those unresponsive, though, of antidepressants, your first line, your second line, SSRI, SNRI, and your even your Wellbutrin, norepinephrine, dopamine reuptake inhibitor, then you could use atypical antipsychotic that has indication for depression. This is your aripiprazole, your Abilify. We will be probably covering that in mood as well as in your psychosis therapeutics. So, but it has some indication also of antidepressant, your Abilify, your combination olanzapine and Prozac, or called Sembiax, your quetiapine or Seroquel, although it's indicated as an atypical antipsychotic, it has also indication of the major depression. Although sometimes its indication is still pending, but clinicians have used this also. So you could also consider after your first line can fail. Some of these atypical antipsychotic can be best used for patients with bipolar or psychotic feature that is presenting with depressive symptoms. Always remember that they may have some more adverse reaction, and you got to monitor this adverse reaction. And this atypical has high risk for metabolic effect. So watch for weight gain, document, monitor the weight, look at their lab works, their lipids profile, because they may increase dyslipidemia, and also monitor for A1C because they may increase the risk for hyperglycemia. That's another disadvantage in using this atypical antipsychotic, which is less when you use your SSRI. So options for unresponsive patient, consider an alternate antidepressant or consider also your atypical antipsychotic. Other can be used in certain caution is with your lithium. Usually it can help your depression in 20 to 50 milligram per day. Cytomel or your Buspar can also be used as an alternative. Okay, so that ends our presentation for your pharmacologic management for depression. Thank you so much.